Cushing syndrome. This is hypersecretion of cortisol. So this hypersecretion of cortisol can be either ACTH dependent or ACTH independent. So if this is ACTH dependent, then what are the possible causes? It could be because of Cushing disease from pituitary gland, which is the most common cause, or it could be an ectopic ACTH dependent producing tumor, which are the small cell carcinoma or the foregut carcinoids. It could be because of the corticotropin releasing hormone tumors, which may be neuroendocrine tumors or medullary tumors, or it could be because of excess cortisol administration. Now, if this hypersecretion of cortisol is independent of ACTH, then what are the causes that you would think? You would think about a unilateral adrenocortical adenoma, adrenocortical carcinoma, or bilateral macronodular hyperplasia. Now, what happens because of this hypersecretion of cortisol? Basically, patient presents with a wide constellation of symptoms which ranges from facial plethora, a buffalo hump, where you would find extra adipose tissue on the back of the patient, a moon facies, which you would have seen in your medicine wards or must have frequently heard about it, hypertension, may have diabetes, then may have central obesity and weight gain. So once this patient presents with such clinical features, we go for some biochemical investigation. Now, what would be a biochemical investigation in such patients? We would go for a 24-hour urine free cortisol levels, and we see if it is elevated or not. If it is around threefold elevated, then it is a probable Cushing syndrome. If it is 1 to 3 times elevated, then we go for the second step of the biochemical investigation, which is late evening free salivary cortisol. Now, if this is more than 550 nanogram per deciliter, then it is a probable Cushing syndrome. If it is less than 550 nanogram per deciliter, then think of some alternative causes. Similarly, if this 24-hour free is less than 1/4, then you think of alternative causes. So far we have basically diagnosed that this is a probable Cushing syndrome. Now, this is an image which has been taken from Bailey and Sabiston, which you can see the clinical manifestation of Cushing syndrome, where the first picture, this is your first picture, as mentioned over here, appearance of a man before development of Cushing syndrome, and this would be the same man who has developed Cushing syndrome after a year. and this is some of the pathognomic marks that you can see in case of a Cushing syndrome. Such images might be given to you in your exam, which would help you to identify as a clue to Cushing syndrome. So, having established that this is a case of Cushing syndrome, as we discussed earlier, that it may be ACTH dependent or it might be ACTH independent. So, our further management would be basically depending upon it. So, how do we proceed about it? So, as it says ACTH dependent or independent, so definitely the first step over here to be see whether ACTH is present or not. So we measure the adrenocorticotropic hormone. So this, if ACTH is detectable, then it is what? ACTH dependent tumor. Now if it is not detected, then it is ACTH independent tumor. So in case of ACTH independent tumor, as we know, the important causes would be an adenoma or an adrenocortical carcinoma or bilateral hyperplasia. We would go for thin cut adrenal CT. Now if this is shows that there is presence of tumor, then definitely we would be going for adrenalectomy. Now in case of ACTH dependent tumor, we would go for a pituitary MRI. Now if we find that there is no mass, then we go to the next step, which is a bilateral inferior petrosal sinus sampling. Now if there is a gradient established in this, or there could be no gradient in this. Now if there is a gradient, then you go for transsphenoidal pituitary surgery. If that fails, then you go for a bilateral adrenalectomy. Now in case of no gradient, you go for the chest CT, abdominal CT, a somatostatin study. Now if it is positive, then you go for resection, because this would be your ectopic ACTH production. Now if there is mass, then you need to go for a pituitary surgery. So let's revise this Cushing syndrome again. There is hypersecretion of cortisol, so it can be ACTH independent or ACTH dependent. It can be a Cushing disease from a pituitary or an ectopic ACTH in case of an ACTH dependent. In case of independent, it would be a unilateral adrenocortical adenoma or an adrenocortical carcinoma. So once we come to our clinical features like facial plethora, buffalo hump, moon facies, central obesity, then we do biochemical tests to confirm whether it is Cushing syndrome or not. So we do a 24-hour urine-free cortisol level. If it is 3-fold elevated, then it is definitely probable a Cushing syndrome. And if it is 1 to 3 times elevated, then we go for the next step, which is the late evening free salivary cortisol. Now, if that is elevated for more than 550, it is definitely a probable Cushing syndrome. If not, then we think of some alternate causes. We have an image which might be given to you in an exam taken from Sebastian, which shows a normal man and the pictures of him after 1 year suffering from Cushing syndrome. So having established biochemically the Cushing syndrome, the next step would to be determine what would be the plan of management. So here the next step would be to measure the ACTH levels, because if it is detectable, then it would be an ACTH dependent tumor. If not, it would be an ACTH independent tumor. In case of ACTH independent tumors, we would be wanting to do a CT scan, where if it would be an adrenocortical carcinoma or an adenoma, we would go for a surgery. In case of ACTH dependent, if it is a pituitary MRI, if it shows a mass, it would be a pituitary surgery. If there is no mass, then we go for bilateral inferior petrosal sinus sampling. If the gradient is established, we go for a transphenoidal pituitary surgery. If fails, then we go for a bilateral adrenalectomy. Whereas if there is no gradient, then we go for a chest CT and abdominal CT and a somatostatin study to see if positive, then we go for that tumor resection because it would be the ectopic ACTH producing tumors. The bilateral inferior petrosal sinus should be remembered over here as just the next step, and we won't be discussing that in details. So that is all for the Cushing syndrome. Thank you.